Thank you so much for joining us on Scrubbing In. I'm Todd Schlosser, your host, and joining me today is Charles Yarnall, who is our National Clinical Specialist and Chief Perfusionist at Abington Memorial Hospital.
It's nice to be here, Todd.
Thank you very much for joining us today. I really appreciate it.
You're welcome.
So I wanted to talk to you today a little bit about your background and what led you into where you are now, and also some unique relationships that developed because of your position. But I wanted to start out with what got you into the medical field? What was it that drew you to that as a career choice?
Well, actually, more than 25 years ago, I was actually interested in going into nursing program at the time, and I was going. I was actually at Temple University. I was, putting in my time learning my didactics, and at that time, just when clinicals were going to be coming up, I was actually just by chance introduced to the term perfusionist, and there just happened to be a friend of mine whose husband was a perfusionist. I just graduated, was working over at St. Christopher's Hospital. His name was Chuck. He actually he still works with the specialty care. He had come on a number of years ago, and he said, "Well, Charles," he said, "if you're willing to take on what might be the most interesting career of your life, I'll have you come in. Here's a pager, and when I call it, give me a call, and we'll set you up, and we'll get you to look at what actual open heart surgery is."
So this is, if it was a pager, it had to have been mid-90s?
It was, yeah, that's right. Yeah, in the very early 90s. Yeah,
so
early 90s.
Is that when you graduated? Did you graduate from Temple?
I didn't. Actually, at this point, I had my associates, which is what you needed to get into a school of perfusion. So at this point, I was like, oh, okay, well, gosh, I might have the credits if I decide to make this a career choice. And after watching this case with Chuck at St. Christopher's on a newborn child that had to go open heart surgery, and actually was a transplant that had occurred, and the other perfusionist went with one of the other surgeons, acquired the heart and brought it back. I got there 6 o'clock in the afternoon. I didn't leave till 6 o'clock the next morning, and at that point I was just sealed that perfusion was what I wanted to have as a career choice.
Wow. Okay, so just to make sure I understood what you said, your first time ever seeing perfusion as a job, as not necessarily as a perfusionist, but sort of witnessing it. You saw it on a newborn child doing a heart transplant.
That's right.
I can think of a no higher stakes situation for you two. And now I realize you weren't actually doing the perfusion job at that point. You were just observing, but that seems. Oh man! So that solidified that moment solidified your desire to go into perfusion school.
Yes, it did.
And then that perfusion school took 2 years?
It took 2 years.
And that was from 94 to 96?
Yes, right. Yep.
So when you leave perfusion school, where did you end up?
Actually, I was hired by the university I was at for the School of Perfusion, which was Hahnemann University. And they asked me when I graduated to come there and be a part of their team. And it was actually one of the largest heart programs in the area. It was at Hahnemann University was doing routinely 1,800, 1,900. We were scratching the ceiling with almost doing 2,000 hearts that year that I graduated.
Is that just out of one hospital, one university hospital?
One hospital was doing about 2,000 hearts.
That seems
back in
like
1996.
A lot.
It is a lot.
A lot of a workload. So there must have been quite a few on-staff perfusionists and on-staff doctors there.
There were. There were about a dozen surgeons. There was about 13 cardiovascular perfusionists working there, and there was a school of perfusion there. So there's about 12 students rotating through there. Each one was seeing hundreds of cases.
In that sort of setting, and I realize that, in your situation now, you work primarily with one surgeon. Is that the case?
Actually, about 3 surgeons.
Okay, so it's still a tighter-knit community, if you will, than when you're doing 2,000 hearts out of one hospital.
Right.
And one of the things that I wanted to talk to you about is sort of teamwork and building a team. So when you have that many surgeons and that many perfusionists and, other like scrub nurses and other people who are in the OR kind of on that surgeon's team trying to get the surgery completed with successful outcomes, is it hard to develop a work rapport with that big group of people? I'd imagine those type of relationships form easily or in smaller groups.
Yeah, you're absolutely right. The smaller the group, the easier, and the larger, the more difficult it is. But there's a unique bond that occurs between a perfusionist and a CT surgeon, because they understand that you're providing the life support, keeping that patient intact, so that all the work that they do on the patient at that time, that they're still going to be completely intact because of your efforts behind the pump. Because when you put them on pump, you turn off their heart, you stop the ability for the anesthesiologist to do any meaningful respirations or to oxygenate the blood. It's all in your machine. And so even though there was about 13 different cardiovascular perfusionists and 13 different surgeons there, we all knew each other on a first name basis.
I'm sure.
And worked very well together. There was about a handful of nurses, about a dozen nurses, and CT, specifically trained CT anesthesiologists. And even though we were so busy because we were there for long hours, we became quite intimate. But where I'm at right now, with a smaller group and a tighter group, there's even a more intimate relationship when it comes down to, I actually know some of the people's favorite colors.
Yeah.
And I can tell you at Hahnemann, that never came up. It was almost like, what are you going to do when you get out of here? Sleep? Yes. Okay.
Yeah.
That's
sleep. Yeah. Me too. Let's move through it. Yeah.
Right.
My father was a huge baseball fan. So it seems like, because he would always talk about how a certain pitcher plays better when he's throwing to a certain catcher.
Yes.
And I'd imagine that's somewhat similar and maybe not throws better in the sense of does better surgery, but I'd imagine there are some nonverbal communication that forms between, a perfusionist and a surgeon, when you've worked with someone so long.
There are. And some people say, some things go unspoken and get done and stuff like that.
Yes.
And in the past, I can say, you did things because you knew that's what the surgeon wanted. But now in today's surgical environment is what you now know to do, is not to do things without it being spoken, but know when to speak up, know when things are supposed to happen. So actually being familiar with a surgeon and an anesthesiologist, you know that when things don't flow in the normal manner that they do, to speak up, to say your piece, to communicate the variable that is occurring so that the correction can happen quickly. So that familiarity happens, but it's so that you can communicate even better. The problem with you have new people who haven't worked together is that you worry, should you speak, shouldn't you speak, not whether you should speak, but how much you should say, and what will they understand, and what words are they using that you can get their attention with.
And imagine, just like in any relationship, communication is being sort of a vital piece of that in the OR in such a high-stakes environment that is even more so important. Is it difficult coming into a new situation with a new surgeon, or if you step into a new role at a hospital, or you're with a new team? Is it difficult to be able to speak up?
It could be, but it doesn't have to be. It all depends on what you're willing to do. And what I mentor every perfusionist that I've trained, that has been a student underneath me, is I try to make sure that they are very comfortable with communicating to that surgeon. That when you speak up. You make sure that what you say is heard the first time, and not that the first time you speak to the surgeon should be when he's on one side of the operating table and you're behind a pump. You should speak to the surgeon before getting in that situation. You should say, "Hi, my name is Robert, Joey, whatever,"
before
a
surgery.
rapport, and just say, I hear that from the other perfusionist who I was watching, who's pumping your case the last time, who was orienting me to you, that you like to cool to this, you like to keep your pressures about here, and so on. And then he says, yes, that's correct. And then he might even direct you, if there's any deviation or something like this, make sure you speak up. The only wrong question is the one that you don't ask me, because I don't like any surprises, and I want to make sure I can help you do your job as you were helping me do mine. I'm like, those are the kind of surgeons and anesthesiologists that I find in the field nowadays, which is just fantastic. And thus it's a really great time to be a perfusionist, if you don't mind me saying.
No, I definitely don't mind you saying. No, I do understand that there is sort of a perfusionist crunch going on, because there aren't as many perfusionists as there is a need for them.
That is right. I believe that the statistics out there right now is that over 50% of the perfusionists out there are over 50.
Yeah.
I happen to be one of them.
I didn't want to place it.
Yeah. I just say, I won't give you a number, but I'm just saying I am over 50. And there used to be over 20 schools of perfusion out there when I was in perfusion school. And now there's somewhere arguably between 10 and a dozen schools out there. That's it, putting out perfusionists. As a matter of fact, because I'm lucky enough to work with a CT surgeon, Dr. Mauricio Garrido and Dr. Rohinton Morris, and they saw the need as these schools were drying up to help foster another school. They actually put their full weight behind opening a school of perfusion at Jefferson School of Perfusion in Philadelphia, and with no short help of specialty care to help it get it up and running. Yeah. It's completely independent of specialty care, but they helped facilitate some of the materials that we needed and equipment so that we could have a simulation lab that we have what I would say is one of the best schools of perfusion that are putting out phenomenal graduates. As a matter of fact, our first year that we had, which was a year ago, the graduates, we hired 3 out of the 6 graduates, and and they were just top-notch, graduates that are now about to take their boards and become nationally certified as a cardiovascular perfusionist. And it's we have people that are training them that I've known for years, worked with, that have the highest quality in mind in doing that. And so there is hope for perfusion.
I hope so, because it's a vital part of surgery.
Absolutely.
Anytime the surgeon has to go in there and operate on the heart, you guys have to be there to keep the patient going during that time, because there's no way to do that without.
That's right. No one else stops the heart but the perfusionist, with the cardioplegia that we give, cardioplegia cardio, heart, and plegia paralyzing the heart. And then once that happens, you better have a machine that can take over the function of the heart and the lungs to keep that patient going.
Yeah, got to oxygenate that blood.
Oxygenate that blood, remove that CO2, keep the pressures where they need to be, keep all the organs happy, prevent acute kidney injury, keep mental status the way it was pre-operation. It's a lot of balls in the air, but it's satisfying as a job as I've ever known.
I've talked to quite a few perfusionists through Scrubbing in the podcast, but also just in the halls here at Specialty Care, and the amount of things they have to account for always sort of blows me away, because all the things you just mentioned. It's not just blood volume and levels. It's how are the organs doing, how much oxygen is in the blood, and is it getting passed through the body correctly, and also brain function and stuff like that has to be a concern. And so when you're in a job where if you're not at the top of your game and things go wrong, the worst can happen.
Yes.
How stressful is that? And I'd imagine you've been doing it so long that it may not be as stressful as it was on day one for you, but it's got to still be stressful.
Yeah. And as I was saying, this is one of the best times in the career or in the of perfusion to be a perfusionist, is because back in the day, back in the 1980s, 1990s, there wasn't things that we have now which we take for granted, such as cerebral oximetry monitoring, which is actually measures the saturation of the frontal lobes of the brain, which can actually tell you how you're doing or in your objective as a perfusionist, perfusioning the organs in the body, such as the brain. We now have data that can be fed back to us live, real time, that we can use to manage how we're doing our job, whether we need to increase our flows, increase our pressure, and stuff like that. There are many devices out there that can give us immediate feedback on what we need to do. We have blood gas analyzers, which are now directly on the heart-lung machine we can run a blood gas. We can see if we're building up lactic acid. We can see if the CO2 is building up. We actually have many axillary devices which are at the fingertip of the perfusionist to let us and help us do our jobs. And of course, one perfusionist being a lone ranger and not being backed up by others is something that has basically fallen by the wayside. We have backup and we have teams, and you have your wingman, if you would, that are there that can help manage any kind of situation which could arise. Matter of fact, building the team is something that, if you don't mind me saying, specialty care has facilitated that we've been able to do even better than other times with working with any other any other previous companies and entities. And I've used that to help give better care that is seen not just by the perfusionists that don't feel like they're alone, but the surgeon and the anesthesiologist are like, hey, Charles, it's you. Who's coming in to back you? And I'm like, it's Derek, it's Dan, it's Megan, it's Mark, or so on. They're all underway because we have that second tier always set up in case of emergency. So
that's actually in the OR with you.
So you
have two perfusionists in the OR with you at all times?
They don't have to sit next to me, but they have to be able to come within a moment's notice, which is like 2 minutes. So they're in another part of the hospital.
So if you're having some issues, or I mean, just questions that you need a second set of eyes on.
That's right.
You can say, hey, can you come in and take a look at this? And you have another set of hands, another set of eyes, another brain there to help you out.
And there's always people like, when you talk about team, you have nursing. Nursing can be a great deal of assistance to the perfusionist. Yes. We have, with Karen Ritchell, who's our director with CT surgery, it's fantastic. But when it comes down to where you need a perfusionist who knows the ins and outs of your heart-lung machine, has the experience, it's nothing like having another perfusionist there. And that has just been, it's made doing this job for as long as I've done it that much more enjoyable.
Yeah. One final question, maybe a few more.
Sure.
It depends on how you answer it. No.
Sure. Okay. What's the quick out?
So one final question. When you're in that atmosphere in the OR.
Yes.
Yeah. I'd imagine trust is very important.
Yes.
And not just a trust that you know how to do your job, but trust that other people know how to do their job as well. Because you can only handle the heart-lung machine. You, as the perfusionist, can handle that. But you've got to trust that the surgeon knows what he's doing. Mm-hmm. You've got to trust the anesthesiologist to know what they're doing. Yes. So is that a frustrating dynamic sometimes, or is it?
Yes. Here's the thing. I know what you're looking for, and actually that is a key point that I actually make to every perfusionist I work with and every student that I'm training, is that you, through the patient, are connected to every other modality in the operating room. The anesthesiologist who is running vasopressors or vasodilating agents before going on bypass might accidentally keep them running, and it's affecting your blood pressure. You can't get the blood pressure down, or you can't get it up, and it's because of something you're working. The nursing that's at the surgical table, what comes back to your pump through the sucker, which goes into the chest of the patient, can either bring stuff you do want or stuff you don't want, depending on what they're sucking on, or stuff can sit there that should come back to the pump that isn't, because you need them to actually go and bring that fluid back to the pump before it ends up sitting in the patient. The surgeon places the actual venous cannula that brings the blood back to the pump. So you have every other modality in the room directly affects what you can do to sustain that patient. So you have to have that rapport. You have to have those lines of communication, and you have to develop that. And that should be something you focus on a daily basis. So having a good rapport, having familiarity with the people in your room is key and paramount. And because of the many initiatives which have been put forth, not just by perfusion, but through nursing and anesthesia to bring these teams together, it just has made, in the last several years of my life as a perfusionist, have been just that much better, because everyone has been focusing on safety and communication.
Excellent. It's a great way to answer the question, because I like to focus on that, because you are only in control of what you're in control of.
Right.
But there are things that impact you that you don't have control of, but you have to roll with.
Right.
So that, and I imagine, even though you have trust in those people, to be able to communicate in a way that is professional, but also
it's got to get done.
It's got to get done.
You got to help me. That's right. So
not aggressive is not the word I'm looking for, but
you need to get
definitive.
Definitive.
Yes.
It needs to be precise.
Yes.
To the point, non-distracting, and clear. And those points to be made on communication, which is actually what we were speaking at earlier today. Dr. Mauricio Ingrido and I at a meeting, and we were talking about communication and collaboration, and what we've learned about working together with each other for 7+ years.
Yeah. Let me ask you one final question.
Sure.
I just thought of this.
Thanks.
Since you've been in the industry for so long, what would you tell those...
Other people have been in there longer than me. So there's older perfusionists than me out there.
I'm sure. Yeah, it is an aging population.
That's right.
And
Yes.
Specialty care does focus on trying to get more people to enter that realm. So what are some things that you would tell people who are looking to, like they've just graduated nursing school, or maybe a bioscience degree on some level? What would you tell them in order to maybe convince them, or just if they had general questions about perfusion, what would be a good starting place for them to start looking into, maybe this is what is for me? Because not everyone's going to have the chance to go witness a heart surgery of a newborn child.
Right. Well, there are the schools of perfusion that are out there all have, and again, because of the web, there are web pages out there. You can Google the American Board of Cardiovascular Perfusion, which actually lists all the active perfusion schools that are out there. That will direct you to the individual websites of the schools that are out there. And you should be a person who can juggle several things at the same time. Someone who can deal with stress. Someone who is looking for a challenging environment to work in. Someone who wants to go home knowing that you've made a difference in someone's life every single day. I mean, there's something to be said for balancing a checkbook, for balancing the budget plan for an institution and stuff like that. And they're all very rewarding. But on a daily basis, you have people in the worst point of their life who need to undergo open heart surgery to be put on the life support device and maintain in a way that they come out as good as they came in. That if you don't have good people there, good things don't happen. And getting good people who want to come out and know that they made a difference in a team that has the exact same viewpoints as you on having the best outcome for a patient is just rewarding beyond compare. I just think about some of the options that I had that would have been great, but I would never have hit the same highs of satisfaction that I have now being a perfusionist for as long as I have, and actually being privileged enough to be a part of a school of perfusion and to have taught people and have students come back to me and say thank you and also thanks for the direction, thanks for the discipline, thanks for making a difference and stuff like that. And they're going out there because there's a chance I might develop coronary artery disease. There's a chance I might end up on a table one day. And I would love to have the privilege of looking up and seeing my best student behind a pump who has graduated and truly maybe even become a chief perfusionist somewhere say, Charles, you rest assured, I got this. You're going to do fine. Yeah. Because some of my friends have had that exact scenario happen. And they said, boy, I'm glad we have all this technology right now that records what we do behind pump, because I could review my own record and they did such a great job and I feel fine. And so they believe in the system. You live the system. You have great outcomes. And being a part of a system that emphasizes protocol and, like we have here at Special Care and outcomes-based medicine, it just is like hand in hand. So it's been very happy and very rewarding.
Well, thank you very much. I can't think of a better answer to end on. But Charles Yarnall, thank you so much for coming in and having this conversation with us. We appreciate it.
Thank you very much. It's been my privilege to be here.